Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
I'd like to welcome you today. This is Frank Cutitta, host of Health Stealth Radio. I've got a great guest today that I've been a big fan of for a few years. John spoke at one of my patient experience symposiums a couple of years ago, I guess a symposia, and it was a huge hit. And I've done some reading and followed him in some of the innovation he's done at the Veterans Administration. So, John, just for the benefit of the audience, could you do a brief intro of a day in the life of the Veteran Experience Officer? And we also try to tie something light, given it's the summertime. Is there anything fun you did this summer that you want to talk about?
Wow. Yeah. Well, thanks again for having me, Frank. It's great to be reconnected and really excited to be on the show. So a day in the life of, and I'll go to my fun thing in the summer because I'll have to think about that too, because it's been a great summer, summer of George, indeed. But a day in the life of, it's really kind of thinking about taking a look at all of the data that we capture, be that through surveys, be it through our qualitative ethnographic research projects, like analyzing the different patient journeys that we have in the healthcare system, and translating that into how decisions are made here at VA, and ensuring that I'm relaying that information to senior leadership of the agency and to the Veterans Health Administration, Veterans Benefits Administration, et cetera. So we collect all that data in a number of ways, like surveys, like a lot of healthcare systems, but we also do a lot of human-centered design research and a lot of service blueprinting and process improvement and training. So we take all that data, we go out and we train the facilities and our employees, our 430,000 plus employees across the country, on how to deliver a world-class patient experience. We also do a lot of customer communications. We take all those design insights and survey insights and then design ways to better communicate with our veterans, their families, caregivers, and survivors. So that's kind of like a day in the life of, is coordinating a lot of that and making sure that elements of the enterprise here at VA are kept updated, and that we're partnering very well with our facilities in the field, because our job here at headquarters is to support our VA medical centers, our outpatient clinics, our vet centers, our mental health outpatient centers, and our benefits offices and cemeteries nationwide. In terms of this summer, I just a buddy of mine got married in Italy, so I got a chance to get over to Florence for an outdoor wedding, which is unheard of because I'm from Texas and it's really hot here in DC in June, right? Late June. Right. So to have an outdoor wedding was pretty amazing, and then go down to Tuscany and then down to Salerno, where we landed a lot of troops in World War II. And got to, especially from Texas National Guard, it was neat to participate in that.
One of the things I'm most excited about in speaking with you, and it's a personal gripe of my own, because I had my own patient experience where I was in a coma for 45 days and spent 100 days in the hospital with COVID. But one of the things that I know that you're doing that's a little bit different, if I've gotten it right, I've always had this beef about the patient experience surveys being done like the week after I get out. So I've always wondered how healthcare enterprises can become more instance-based in terms of the patient experience or the veteran experience as it is. I'm wondering, from what I understand, you've made movements in that area of trying to be more instance-based in those experiences with veterans, so you could capture it when it might not ever come back afterward.
Yeah, and that's a really interesting insight, and I'm glad you're okay. First of all, 100 days is a really long time to be in the hospital, and gee, what a crazy few years COVID was for everyone. But it sounds like it's especially for you. So I'm glad you're all right.
Success story.
It's good, yes, and that's good to hear. And it's a really interesting insight. You probably, in that 100 days, you could have gotten a couple of pulse surveys, right, to be able to measure your experience and then conduct service recovery along the way, instead of having some good experiences and bad experiences and then have to answer one survey to capture all of it, which is almost impossible. So we are currently taking a lot of insights from our facilities in the field, and we're putting together a rounding tool that'll essentially be used by clinicians, by staff, by hospital leadership, by clinic leadership to address those types of concerns and then report them in an electronic way using our Veteran Signals platform. And I think that's kind of, like you said, the future for a lot of the patient experience organizations is more pulse, not just individual instance or individual experience surveys. And VA, we usually send our outpatient care visits and specialty care visits. We usually send our survey a couple of days after your visit. So
Makes total sense. Makes total sense. Sure.
Not a lagging. I mean, yes, of course, we still use SHEP surveys, and that's a lagging, survey 3 months later kind of thing. And you have to think back to your experience 3 months afterward. But, so our V signals is more instantaneous, albeit not real time. But we are thinking about pulsing through what we call our We Care leadership rounding. And so we want to build a tool that actually helps our leaders and our staff and clinicians enable that reporting so that service recovery can be conducted along the patient journey.
You ever see it getting to a point where somebody could do it on their mobile device themselves, like hit the button?
Absolutely. Yeah. That would be, I think, ideal. We're not there yet. I think that's a really novel idea that to take. It's always good to test things with employees because they're incredibly competent, driven professionals that are mission oriented here at VA, and they test these types of things. And eventually, if we could take that rounding tool and convert it into a patient facing modality, that would in a more of a pulse opportunity. That may be a real solution down the line.
As you mentioned, part of your responsibility, I mean, you've got so many different kinds of data feeds coming in as technology increases. I'm just wondering, as technology grows, what kind of new insights and what kind of new metrics are you seeing that you just said, well, 3 years ago, we couldn't even dig into something like this?
I think we didn't understand the inpatient journey as well as we do now. We just started measuring that 2 years ago. And found that there are some big pain points in that discharge journey, in particular from the inpatient journey, whether it's 100 days like yourself or just a few days post surgery. We then took the insights from that, the surveys and the qualitative research that we did, and we created a virtual reality training experience for our clinicians and staff that support the inpatient bed units in our hospitals. And we've deployed that to like 20 different sites now, and we're deploying it even further. And it's a really neat thing that puts you in the seat of the patient, and the doc or the nurse will come in and put the discharge time on your whiteboard, and then come back in and scratch it off and change it. Well, meanwhile, your family's like texting you, and you have a cast on. It's really neat and immersive, and you can hear the nurse talking in the hallway to the discharge nurse, and like there's fumbling, and so you're getting frustrated. You can see the clock kind of going in elapsed time. And it's really cool because we put the secretary, McDonough, in the training, the deputy secretary Tanya Bradshaw, and then we put undersecretary for health Dr. Sharif El-Nahal for the training. You could see as they were going through the experience just how frustrated they were becoming as the patient. And then I think that really helps not only our strategic level leaders, but our operational and tactical level clinicians and staff really understand how to improve that experience.
So it must be an interesting challenge trying to build emotion into these kinds of virtual reality programs. I mean, because it's easy to be on a roller coaster or go through Jurassic Park in virtual reality. But I mean, actually, considering the empathic aspects and the compassionate aspects of being in a ward as a patient and having the physician or the clinician say, I'll be back in a minute. And the next thing you know, it's 60 minutes, it's 90 minutes. So I mean, that must have been a great challenge in terms of the algorithmic aspects of this.
It was. But I think we did a good job at putting together a training that reflected the pain points of that discharge journey. And we've seen the increase in scores in the facilities that have deployed that virtual reality training tick up by 5%, like by 5 points in the intervening months, which is pretty incredible. And so that's really the sales pitch for the rest of the facilities. Like, hey, we'll send you a set of goggles if you can put your folks through one by one that are on the inpatient units. And I think that's the how we kind of diffuse this type of training and improve the patient experience.
I mean, you have such a diverse patient and veteran base with the elements that they have. Is this being used in things that are more on the outpatient side?
Yeah, there's a bunch of different virtual reality experiences that we're developing. This one is really one of the only ones focused on improving a specific patient experience journey, right, like patient discharge journey, because it was so riddled with pain points. Mm-hmm. We're in 2018, we did our outpatient outpatient experience journey map and service blueprint and insights report. And I think that really, at that point, we were at 85% trust. Now we're at 93% trust. So in the intervening, 6 years, we've really hit, done great things. Mm-hmm. But where the rubber meets the road, I mean, in terms of just the actual scores, is the qualitative comments that we get back from the surveys, that we follow up. We conduct service recovery on every single survey, whether it's a compliment, a concern, or a recommendation. 70% are compliments, by the way, and 30% are concerns and recommendations. Great. So the fact that we're following up with those concerns and recommendations really kind of shocks the veteran in a lot of ways, or the veteran's caregiver in some cases, and making sure that we're increasing that trust and showing that we can do that. So the outpatient journey having been done in 2018, we're redoing that this next year, 2024, 2025. To really think about like kind of this post-COVID, it's a hybrid environment of in-person care, it's telehealth, it's virtual care, it's community care, like, sending out and referring out for specialties or primary care when we can't serve the veteran within a certain number of days or a certain distance to their home. So I think that's going to really, that refresh is going to show us a lot of things that we've done right in the last 6 years, mm-hmm. and a lot of opportunities for us to get even better in the next 6 years.
So I was thinking, when you talk about the qualitative aspects being the most powerful, many would argue, and I hear in the classes that I teach, that 80% of healthcare data is unstructured. So I'm curious what you're doing now to capture what could be the most valuable information out there from these veterans and from these patients. What are you doing to capture that, the most important 80%? Not that the 20% isn't, but it's just not the same.
We want experience metrics to be a co-equal measure to kind of the operational data, like number of appointments completed, number of surgeries, number of discharges, et cetera. We want to provide hospital and clinic leadership all the way down to the individual service line, that dashboard, that full site picture of operational metrics and patient experience metrics, so that they can make informed decisions about staffing and other resource needs throughout their career. Like some of the other opportunity that lies with that is taking some of the data that we're getting from other sources, like be that contact centers, and making sure we're pulling in that data. So you talked about kind of disaggregated data in the fragmented market ecosystem that we're living in. Well, we've been able to kind of pull that together for those patient advocates or those veteran experience officers or those service line chiefs, so that they can now see where that feedback's coming in and what it looks like when they compare it to their operational metrics. So it's been really an interesting journey. The 4 years that I've been involved, we've come a long way at building that system with the insights of the field, and I still think we can always make it better. But that is one good example of how we're kind of pulling everything in for ease of use on the employee side. Because if the employee doesn't have a good experience,
forget it. Yeah.
You're darn right that the veteran's not going to have a good experience.
I was sort of curious. I almost have interviews almost have a fiduciary responsibility to ask about how AI is being used in a lot of the stuff that you were just talking about. I'm just wondering where you are on that evolution and where you see it going beyond the repetitive or mundane tasks.
Yeah, that's a great question. I had a great opportunity to be down in our Orlando facility, which is one of the newer facilities, and it's world-class technology, and then a great ecosystem there in that Lake Nona area.
Oh, it's amazing there. Yeah,
we went from like our SimLearn Center, which is like a fully operational outpatient clinic where we can test a lot of new technologies, test a lot of new hardware, and also training in a synthetic environment. And we walked across the street to one of the other hospitals in the Lake Nona complex. They had already deployed ambient dictation, and we were able to see how it listened to the patient clinician conversation, and then appropriately categorize the actions into the medical record. even down to like the prescriptions that the physician was recommending or prescribing in verbally, which allowed the clinician to, of course, not take their eyes off the patient,
right,
and not to go back and forth to their keyboard, and and I think it enabled a much faster turnaround. They say that they can save a clinician an hour and a half to 3 hours per shift, which that seems pretty. I mean, I was shocked when they kind of told me that, but
right.
That's more patients you can see, that that creates a lot more efficiency. But it also takes a lot of the kind of the tactical work out of that clinician's day, right?
Right.
We're not only thinking about that on the kind of patient facing side, we're also thinking about, if we can once again kind of back to the employee tools that, as I was just referring to, in our patient advocate tracking system, building better tools and technology and training for our employees will all only result in that better patient experience, as I mentioned. We're also looking at using generative AI to help social workers or peer specialists or frontline care management teams to be able to query different questions that veterans have that may not be directly related to that individual patient journey. For example, if I'm at my primary care physician and talking to the nurse, and I ask them about VA benefits and memorial services, they may not know a ton about that. Or then so they would be able to query this tool that we've built and tested, and then ask and then look at the narrative response that is provided about a benefits question.
Right.
Benefits is out of their portfolio. And then as a clinical professional, they would determine whether that response would be safe enough to then relay to the veteran. So we're kind of trying to manage.
So you got the filter in between for the quality control aspect.
We want human level.
Makes total sense.
Layer of check, to reduce the risk. We got it to like a 90% confidence rate on some of the responses, but we just want to make sure and build in that layer for the veteran experience and to make sure that to reduce that risk.
Yeah, I mean, and you've seen it. I mean, it's not unique to outside of the Veterans Administration, but the amount of burnout that's caused because of some of these mundane tasks that our clinicians are required to do, and the other aspect that we hear about, I always love the term pajama time, where they're spending so much time in their pajamas at home. Yeah, so I think your point about the generative stuff is interesting, and it's reassuring to hear that there's a human filter in between. I'm just curious how you embed the families into the veteran experience. I mean, obviously, the moment you go into the military, you know it from your deployments. I mean, the family has so many life issues that they have to deal with, in addition to their husband or wife being away. How do you bring the family into bulletproof some of the things that you're talking about?
Yeah, that's a great question. So our mission is to serve veterans, their families, caregivers, and survivors, right? And I think that's important because it is that family unit that addresses that leads to positive health and economic outcomes. And in many cases, our veterans have caregivers that provide for them, and that would, in some cases, rate additional benefits. We have the caregiver support program, which enables veterans to apply for, based on their level of need, their spouse, their father or mother, or their kids to be a primary caregiver for them that can receive some monetary compensation as well as to care for their veteran full time. So that and then we also have survivor benefits. So if a veteran has a certain disability rating from the VA and passes away, and that spouse or significant other is dependent on that disability compensation to manage their household, especially if they're retired and they don't have another source of income, or they were a caregiver and they weren't able to work because they were caring for their veteran. When that veteran passes away, there are some survivor benefits in addition to the memorial benefits and burial benefits that we have, which are like world class. The cemetery memorial affairs. The cemetery administration is constantly ranked, and J.D. Power and Associates is the top cemetery burial organization in the country, which is pretty incredible. So So there are a lot of ways that we take care of our families. We want to design more for that family experience, because especially if we're caring for younger veterans and an increasing number of women veterans are our fastest growing customer cohort population. noting that many of these younger women veterans have children, many of these younger male veterans have children, many of our retired veterans that are elderly are caring for grandchildren or great-grandchildren, and they need childcare provided. We are doing some childcare pilots at certain VA medical center sites that can, if it's a limiting factor to get to your next appointment to provide childcare, well, we want to make sure that you have that ability to do that at a few sites, and making sure and addressing that and studying it so that we can provide that more often. But we do a lot of studying that family experience because it is so critical to making sure that veterans have the great access to these programs that they so rightly deserve.
It's sort of a segue to that because the care models are changing dramatically. I mean, you served probably one of the most dispersed group of patients or veterans, possibly in the world. I mean, they're all over the place. They're rural, they're urban, they're out on a boat someplace. I'm just curious how you're seeing the care model changing. For example, one of the other conferences I ran in a previous life was the Hospital at Home conference. Are you seeing part of the veteran experience or the patient experience moving to the home for high acuity care, not just having somebody come in as a caretaker, because we're out in Illinois. I mean, out in rural Idaho, let's call it. I don't want to pick too much of a farm state. And you just can't get to a VA facility, but I need high acuity care, not just basic care.
Yeah, absolutely. So we're delivering more what we call community care than we ever have before. We're also providing more direct care than we ever have before that are in our facilities, but we're referring out for primary care or specialty care or in-home care, to your point, to partner companies that are approved in our network. And similar to how the military does their TRICARE system, we are referring that care out when that we cannot meet the wait time or drive time distance standards that are set by our system and by Congress. And I think it's important that there are a lot of rural veterans out there. I think it's roughly 50-50, but when we looked at the scores and we racked and stacked rural and non-rural veterans, rural veterans actually trust VA care more than non-rural veterans, which when I did a hearing on this topic in January with the undersecretaries for health and benefits, I was kind of surprised, because typically you think if you live in a more rural area, you have harder access to healthcare facilities in general, not just VA, right? And that would reduce your trust. But in this case, it's not the case. So I think that our rural health team, our rural desk officer team, our Native American team, because a lot of our Native American tribal nations and partners are in rural areas as well. We've really done a lot to make sure that we're addressing and trying to meet those needs as much as we can, both in the direct care system and in the community care system.
It's interesting. You took me partially in a direction I wanted to go anyway. I mean, obviously, you've got a very close relationship with the government, closer than most, if not any, healthcare organization in the country. Are there things that you could see? I know it's always tumultuous, especially in an election year. Don't want to go into that area. I'm just curious if there's anything you see coming from a policy point of view that you're really excited about. You testified, you talk about certain parts of your business. What's the future? I mean, and the other part of that is that we're getting more into the whole governance area. Governance is cool again. It used to be like eyes glaze over. Now, AI governance is very interesting. Oh yeah, cybersecurity governance is very interesting. The intersection of AI and cybersecurity governance is even more interesting because you can't. True. They're inseparable. I'm just wondering what you're seeing in terms of government policy. We have a government affairs department that tracks this as well. That really is the kind of thing that we're hoping we can get this waiver program passed.
So yeah, we are the federal government. We're the second largest agency in federal government behind the Defense Department. So we have about 430 to 450,000 employees at VA. We serve 9 million veterans and family members annually. We're the largest integrated healthcare system in the country. We have 150 hospitals within times 5 to 10 clinics around them, and about 300 outpatient mental health facilities or community-based mental health facilities, as well as 50 regional benefits offices, and another 150 cemeteries. So it is quite an incredible system that is totally publicly funded. And but also, when we look at the patient experience scores, we're largely outpacing the private sector. And we had our CMS and HCAHPS patient experience scores that we published last year, and we just got our patient experience scores for this year, so coming soon. Very good news. Last year, 71% of VA facilities had a 4 or 5 star patient experience rating compared to 40% of the private sector, which is incredible.
Wow, that's amazing.
And we've really moved the needle, especially in the last 10 years since the Phoenix VA Medical Center access crisis that happened in 2014. And this focus on patient and customer experience has really driven that. So we work directly with our state government to answer your question. State government partners, our tribal government partners, our local government partners, to ensure that we're exchanging information and be as careful as we can. In terms of internal governance for AI and cybersecurity, and we have different governance for all kinds of different things in VA, ranging from toxic exposure research, where we connect the science to people's service and see what new presumptive conditions we can create with the Secretary's authority to ensure that the veterans with different cancers are cared for, because we can now connect it to the science. And then we also have AI governance. So that governing body just started earlier this year. And now we're thinking about not just use cases that need to go through and be considered by senior leadership to be deployed to either customer facing or employee facing, but also just how we continue to manage through this change and keep up and not be left behind. And I think that every company, every organization, whether you're public or private, local or national, you're thinking about how you can keep up in this ever-changing age while keeping things secure, to the cybersecurity point too.
Yeah, because it's an arms war of different kind with the bad guys. So this is where it really gets interesting, where they're using better AI than we are. We've sort of run out of our time, and I really, this has been fun. I look at this as part one of what I hope will be another discussion, especially as it relates to the extended reality and virtual reality work you're doing, because I think our audience is largely high-level CIO types and IT directors. So this is really very interesting to them, and they're all trying to figure out how to deploy this stuff and make it work. And have
we'd love to show them, and we'd love to get you the pair of goggles too, Frank. So let's make it happen.
I'll do that. Okay, John. Really, thank you so much, and appreciate it. And again, thank you for joining Health Stealth Radio today, and joining our guest John Boerstler. And this was fantastic. Really appreciate it.
Thanks for having me.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.